Hello, everybody. This is Michael Awad. I'm here at Washington University in St. Louis, and I'm here with my co-chair, Dr. Jeffrey Blatnik.
Hi, everybody.
And we're really excited to have you here for the 4th annual SAGES and SCORE Resident Webinar ABSITE Review. This has become somewhat of an annual tradition for us, and we have about 2,000 folks that join us every year from about 25 countries around the world. So we're really excited that you could make time to be with us here tonight. This year we're particularly fortunate in that SCORE, the Surgical Council on Resident Education, has partnered with us to provide a series of really high-quality ABSITE questions. And I think folks know that ABSITE is based on the SCORE outline, so it's a distinct pleasure to have SCORE as a partner with us officially this year. So we're going to talk about a couple of things tonight. I'm going to just start with some ground rules and how this is going to work. We have an audience response system which makes the ABSITE a little more interactive, the webinar interactive, that is. I'm going to kick us off with the section on esophagus, stomach, and obesity. Dr. Blatnik will go over general abdomen topics, hernia, and spleen. We have Dr. Amber Traugott from Ohio State with us again this year to talk about colorectal and anal disease. And finally, Dr. Adnan Alseidi from Virginia Mason will talk about small intestine, biliary disease, and flexible endoscopy. So really covering a broad variety of topics and kind of high-yield topics that will undoubtedly show up on the ABSITE. I just want to mention SAGES as our sponsoring society. SAGES is the Society for American Gastrointestinal Endoscopic Surgery, and it's really the premier society for minimally invasive surgery in the world. SAGES has been around for a long, long time, but it's really a vibrant and dynamic society that I hope a number of you I know are members of, and those who are not, I would encourage you to explore SAGES. It's really one of the largest surgical societies and surgical meetings every year. The SAGES next meeting is in Baltimore in April 3rd through 6th. And again, it's really just an amazing meeting that is something that has a program for residents and really can get people's careers launched in the surgical society. So again, very grateful to SAGES for putting this on. I'm a member, card-carrying member since 2003. And then again, SCORE. I think many of you, especially those in the North America, use SCORE already, the Surgical Council on Resident Education. The SCORE portal has a growing set of modules for all topics in general surgery, and we're going to be drawing our question bank from this portal. Without further ado, again, I'm Michael Awad. I'm at Washington University in St. Louis. I'm a minimally invasive surgeon specializing in foregut surgery, and I'm going to be reviewing topics in esophagus, stomach, and obesity. So without further ado, here's our first question, and it is a 40-year-old woman with a long-standing history of heartburn on 20 milligrams of proton pump inhibitor, and she gets an upper endoscopy. The biopsy shows at the distal esophagus intestinal metaplasia with low-grade dysplasia. The best course of action for this patient is continue current treatment and repeat endoscopy in 3 years, recommend esophagectomy for dysplastic changes and high risk for adenocarcinoma, repeat endoscopy with biopsy every 6 months for surveillance, initiate treatment for H. pylori to limit progression of dysplasia, or perform a Nissen fundoplication and eliminate need for further surveillance. In the bottom left-hand corner of the screen, you'll see a timer, and we'll have 20 seconds for each question for you all to respond. I'm starting the timer now. Okay, so our time is up, and let's see. So good. Most of you answered correctly. The correct option is C, repeat endoscopy with biopsy every 6 months for surveillance. So intestinal metaplasia, otherwise known as Barrett's esophagus, and certainly low-grade dysplasia should undergo surveillance every 6 months looking for progression or malignancy. Higher dose PPIs are advised for Barrett's esophagus. The role of H. pylori in Barrett's has not really been established and has not really been implicated in dysplasia. The risk of malignancy with low-grade dysplasia is not insignificant. It's as high as 6 to 10% per year, and thus endoscopic surveillance is important. Esophagectomy would be a bit aggressive for this, so it's not recommended for low-grade dysplasia. Nissen is good for symptoms of reflux. However, it's not been shown to treat dysplasia, so a Nissen would not be the correct answer in this case. So next question. Right. A 50-year-old woman presents with 2 weeks post-Nissen fundoplication, complaining of bloating. She states ever since her surgery she has had severe bloating that is preventing her from engaging in daily functions. She asks for a solution to her problem. What can you offer this patient? Discuss how carbonated beverages can help with their symptoms and encourage their consumption. Offer a full-body CT scan. Offer an ultrasound to address her gallbladder. Discuss lifestyle changes and behavior modification with the known possibility of the need for a RAP revision. Okay. So very good. The correct answer is D. And obviously this patient is suffering from gas bloat, so carbonated beverages would not be a good choice. Lifestyle changes, behavior modification. For my folks with this, I tell them it generally will resolve. I tell them to avoid carbonated beverages. I tell them to avoid drinking through a straw when you can take down a lot of gas when you drink through a straw. Dimethicone products can be helpful, brand names like Gas X and these other things. And then finally, in really refractory cases, and this is very uncommon, sometimes they may need a revision to either a looser wrap or a partial fundoplication. We'll go to the next question. This is a 54-year-old man with GERD and esophageal dysphagia, diagnosed with a 9-millimeter distal esophageal peptic stricture. What is the appropriate treatment? Esophageal stricturoplasty through a left thoracotomy, excision of the stricture with circumferential endoscopic mucosal dissection, serial esophageal dilations, until the symptoms resolve, and initiation of proton pump inhibitor therapy, and per oral endoscopic myotomy, otherwise known as POEM, at the level of the stricture. All right, good. So a little bit of variance on this one, so let's talk about this a little bit. The correct answer is indeed C, esophageal dilations until symptoms resolve. So the peptic strictures can be dilated using a couple options. You can use a freely passing bougie, otherwise known as a Maloney or Hurst bougie. You can do over-the-wire bougies, such as a Savory bougie or a balloon, or through the scope, balloon dilators. The strictures can be serially dilated, but no more than 2 millimeters each successive section, so you avoid perforation. And you can keep doing this until symptoms resolve. There's other options, but excision is not a recommended treatment for peptic strictures. PPI should be started to prevent recurrence of the stricture, but it's not really a treatment for the initial symptomatic stricture. And then per oral endoscopic myotomy or POEM is not recommended for peptic stricture. All right, next question. A 57-year-old woman with scleroderma presents with dysphagia and chest discomfort after eating. A barium esophagram demonstrates an atonic esophagus with free reflux of gastric contents. Upper endoscopy reveals severe esophagitis. What is the most appropriate treatment? PPI therapy, Nissen fundoplication, Toupet fundoplication, POEM procedure, or calcium channel blockers. All right, this is a good one. So great, we need to talk about this. This patient has kind of a sclerodermatous esophagus, and this is a tough condition to treat. Really not a lot of great medical or surgical options, but really kind of the textbook answer is the best first-line treatment is an aggressive medical anti-reflux regimen with PPIs. With the atonic esophagus, the anti-reflux procedures often worsen the dysphagia and are generally contraindicated. POEM, the jury's still out on POEM, as well as other types of myotomies for people with sclerodermatous esophagus, but generally not considered to improve the patient's symptoms. And calcium channel blockers are more for primary esophageal motility disorders like diffuse esophageal spasm or nutcracker esophagus, but not sclerodermatous esophagus. Next, a 46-year-old man presents with a 3-year history of intermittent solid food dysphagia with no progression. He feels pressure in the retrosternal area, especially when he eats steak. He has never had a problem drinking liquids. He denies heartburn, choking, regurgitation, and weight loss. He's otherwise healthy and takes no medication, which is most likely to be the appropriate treatment. Esophagectomy, PPI, endoscopic radiofrequency ablation, percutaneous gastrostomy tube placement, or serial esophageal dilation. All right, good. Most people got this one, serial esophageal dilation. Kind of similar to our previous discussion, this is really the treatment for benign strictures, which we presume this patient to have. Most of these cases are due, dysphagia are due to benign strictures. So first-line therapy is serial dilatations. As we talked about, no more than 2 millimeters increase with each session until the symptoms resolve. You can repeat this multiple times. Esophagectomy, again, is really unnecessary for benign strictures and overkill. PPIs can prevent recurrence, but not for initial therapy, and the other choices are not really appropriate either. Next question. A 52-year-old woman presents to your office complaining of food that gets stuck in her esophagus and persistent epigastric pain. You perform an EGD, which shows esophagitis. An upper GI series reveals a type 3 paraesophageal hernia. You order manometry testing, which reveals impaired or weakened esophageal motility. What is this patient's best surgical option? Nissen fundoplication, Colles gastroplasty, Door fundoplication, or Belzi Mark IV procedure? All right. Good. Let's talk about this one. So, this is a patient with a large type 3 paraesophageal hernia who's having symptoms. He's certainly having pathologic reflux because he has esophagitis on the EGD. So certainly surgical treatment is recommended. Now, of course, what's not stated here but is implied is for all of the surgeries, we're going to repair the paraesophageal hernia first. So we're going to reduce the hernia contents, namely the stomach. We're going to reapproximate the crura, either primarily or with a biologic tissue. And then finally, we're going to do a wrap. The wrap type depends on the motility. So a Nissen fundoplication would be appropriate if the patient had normal motility. However, this patient has impaired motility. So a partial wrap would be the best choice. A door fundoplication or a partial anterior wrap, or a toupee fundoplication, which is a partial posterior 270-degree wrap, would have been appropriate answers here. A callus gastroplasty is only appropriate if you cannot get sufficient intra-abdominal esophageal length, but that's not stated in this question. Belsey Mark IV is an uncommon procedure that's rarely done and usually only done for when there's insufficient fundus to use for a fundoplication. All right, next is a 30-year-old man presenting to the emergency department with 3-hour history of neck discomfort and odynophagia after eating chicken wings. Vital signs are within normal limits. Physical examination is without significant abnormalities. X-rays of the neck, chest, and abdomen show no signs of foreign body or intestinal obstruction. What is the next best step? Barium esophagram, upper endoscopy, supportive therapy, oral gastric tube suction, or CT scan of the neck, chest, abdomen, pelvis with oral gastrograph in contrast. All right, so correct answer is upper endoscopy, although a number of people selected some other imaging modalities. So let's talk about this one too. So plain films can identify a number of foreign objects and can certainly show free mediastinal or peritoneal air. They can sometimes show the number, location, size of the ingested bodies. However, certain things like fish or chicken bones, plastic, wood, glass are often not seen on plain films. So you might want to get additional imaging. The problem is getting contrast studies can actually make subsequent therapy worse. So barium, has anybody seen a esophagus or stomach after barium ingestion? It is thick, coated, white, chalky stuff, and it makes inspection of the mucosa very, very challenging. So we try to avoid that in this setting. Similarly, CT scan with oral contrast can also interfere with the subsequent intervention. Upper endoscopy is your best choice here, where you want to go down and have a direct look and see what's in there, and certainly it will be the treatment you're going to need anyway to remove the foreign body. Next question. A 20-year-old female college student presents to the emergency department after an apparent suicide attempt. The patient drank roughly 500 cc's of an unknown liquid from her chemistry laboratory. The patient is speaking in full sentences without respiratory distress and has mild epigastric discomfort. After establishment of airway patency and hemodynamic stability, as well as placement of IV access, what's the best next step? NG tube insertion, induction of emesis, oral dilution with water, glucocorticoid administration, or urgent endoscopy? This is I'll say this is a classic ABSITE question. Good. All right. So let's talk about this one. So again, classic ABSITE question. So one thing we want to do, we want to avoid kind of diluting the ingested material with any additional fluids. So we don't want to dilute it with any water, especially with caustic fluids. We also don't want to induce any emesis because it can also, we don't know what kind of damage is there, and it can result in esophageal tear or perforation. And we don't want to put any NG tubes down blindly until we establish what the extent of the mucosal injury is. So upper endoscopy should be done as soon as possible after the ingestion, ideally within 24 hours, to assess the magnitude and extent of the injury. All right, next question. A 40-year-old woman who underwent a highly selective vagotomy 1 year ago for intractable ulcer disease returns with recurrent abdominal pain. What is the most likely cause of her symptoms? Gastric atony, dumping syndrome, gastric outlet obstruction, recurrent ulcer, or gastritis. All right. Good. Yeah. So this is an important discussion, as we're not seeing as many of these as we used to. But this patient likely has recurrent ulcer disease due to incomplete vagotomy, which is more common with selective vagotomies as opposed to truncal vagotomies. It's really important during a selective vagotomy to avoid leaving any small fibers behind to avoid this. The so-called criminal nerve of Gracia, the branch of the posterior vagus nerve, has to be included in this resection as it's often associated with recurrent ulcer disease. The other options are less likely because post-vagotomy syndromes are less likely with a highly selective vagotomy, which is what this patient had. All right, next question. A 55-year-old man with an upper GI bleed secondary to a bleeding duodenal ulcer continues to require several blood transfusions after 2 EGDs and attempted interventional radiology embolization. He has known peptic ulcer disease and has been taking proton pump inhibitors. What is the most appropriate next step? A repeat EGD, a gram patch repair, gastroduodenal artery ligation, vagotomy, or entreptomy and vagotomy? This is another good one, and again, another frequently asked ABSITE question. All right. So indeed, the correct answer is gastroduodenal artery ligation. This patient likely is bleeding from the GDA due to erosion from a posterior ulcer. The GDA can be accessed through a duodenostomy, so a direct incision on the duodenum, and then oversewn with a 3-point U-stitch, ligating the main vessel superiorly and inferiorly and preventing back bleeding with a medial stitch. If the patient is stable in the operating room, then you can do a vagotomy and pyloroplasty because of the known peptic ulcer disease. All right, a 45-year-old man with frequent abdominal pain undergoes EGD with a biopsy. He is found to have a duodenal ulcer. Histology demonstrates H. pylori infection. What do you recommend as initial management? Proton pump inhibitor and H2 blocker, vagotomy and pyloroplasty, proton pump inhibitor and antacid, triple therapy with a proton pump inhibitor, clarithromycin and amoxicillin, or a highly selective vagotomy. Good. All right. Proud of you all. That's amazing. All right. I'm not going to spend too much time on that since everybody got that one correct. So we're going to move on to the next one. All right. A 62-year-old man presents to the emergency department with multiple bouts of hematemesis. On arrival, his heart rate is 124, blood pressure 103/55, saturating 95% on room air. KUB shows pneumoperitoneum. He's taken to the OR for emergency XLAP, and perforation due to an ulcer in the second portion of the duodenum is encountered. How would you repair this lesion? Primary repair with Graham omental patch, Billroth 2 reconstruction, Ruin Y gastrojejunostomy, Billroth 1 reconstruction, and truncal vagotomy. All right, very good. Yeah, anytime you're kind of in an acute setting with a perforation from an ulcer, you can attempt a primary repair, but oftentimes the edges are raw, erythematous. They may or may not hold stitches very well. So the gram-o-mental patch is really an essential part of repair of any kind of acute perforation from an ulcer. The other solutions are not appropriate in kind of an acute setting with a perforation. Next, a 76-year-old woman presents with severe abdominal pain and hypotension. Her chest x-ray shows free air. She is taken for an exploratory laparotomy on pressors and is found to have a perforated prepyloric gastric ulcer. What is the next step in management? An entrectomy with truncal vagotomy and Roux-en-Y, a wedge resection including the ulcer, biopsy and omental patch closure with abdominal lavage, resuscitation, non-operative observation until the patient is stable for the operating room, or entrectomy with truncal vagotomy and Billroth 2 reconstruction. Good. I want to make sure you were listening from the last question. So good. This is, again, a gram patch repair in this acute setting, and obviously you have to wash out the abdomen. The patient's on pressors and has a perforation, so again, kind of formal reconstructive options are not appropriate, especially in a patient that is acutely unstable. All right, we've got time for one more question in this section. A 62-year-old man undergoes a wedge resection on a perforated gastric ulcer in the distal body with 1 centimeter clear margins. Pathology reports a gastric adenocarcinoma. What is the next step in management? No further resection if margins are grossly negative. Distal gastrectomy with 3 centimeter margins, lymphadenectomy and Billroth 1 reconstruction. Distal gastrectomy with 6 centimeter margins, lymphadenectomy and Roux-en-Y reconstruction. Truncal vagotomy with an oncology consult for chemotherapy and radiation, and truncal vagotomy and lymphadenectomy. All right, good. And I know there was a little delay on the poll everywhere thing, but I think it looks like it seems to be working now, and good choices C. Distal gastrectomy with 6 centimeter margins, lymphadenectomy and Roux-en-Y. So with gastric cancer, this is really important. Again, frequently ABSITE is the 4th most common cancer and 2nd leading cause of death from cancer. Gastric ulcers are an increased risk for harboring malignancy compared to duodenal ulcers especially. And biopsies should always be taken at the time of repair or resection. If you do find gastric cancer, it should be excised with 6 centimeter pre-margins because it's known to have a wide lateral spread from the primary tumor as much as 5 centimeters away. Certainly lymphadenectomy should be performed. Whether it's a D1 or D2 is somewhat a matter of debate. All right, well, very good. That concludes our kind of foregut section. I'm going to jump ahead here to our next section. This is a pleasure to introduce my partner and colleague, Dr. Jeffrey Blatnik, one of kind of international experts on abdominal wall reconstruction and foregut surgery, endoscopic surgery. Dr. Blatnik is going to lead our discussion on general abdomen, hernia, and spleen. Welcome, Dr. Blatnik.
Thanks for having me. This has been a tremendous success over the last couple of years. I really wish this was something that was around when I had to take the ABSITE, as this would have been really helpful leading up to the exam. So we're going to try and cover some questions on general abdomen, hernia, and spleen. Hopefully get through as many as we can in our time limit. So let's get started. First question is an 11-year-old girl who presents with 4 days of right lower quadrant pain, fevers, and a white blood cell count of 18,000. She has an ultrasound that's consistent with appendicitis with an adjacent 4-centimeter fluid collection. She started on ceftriaxone and flagyl, has a percutaneous drain that's placed with a drainage of purulent material. You watch her for 3 days, but after that period she remains febrile. Her white blood cell count is now 19,000. A repeat ultrasound shows near resolution of the abscess but a continued phlegmon. What is the appropriate course in management? Switch antibiotics to vancomycin and zosyn. B, place another percutaneous drain. C, perform an appendectomy. D, continue ceftriaxone and flagyl on the percutaneous drain and continue to monitor. Or E, switch to antibiotics to augmentin. Nice mix of answers here, but C is the correct answer, perform appendectomy. So when you think about this one, there's a couple things to take into consideration. She has not improved with percutaneous drainage and antibiotics. She's been on this for 3 days. She's already on an appropriate antibiotic coverage, so switching her antibiotics is unlikely to improve her symptoms. Placing another percutaneous drain, there's no fluid collection on her repeat ultrasound that the drain would be able to take care of. So operative intervention is really the most appropriate answer for her. Next question is a 78-year-old man. He's post-operative day number 6 after a right hemicolectomy for colon cancer. Is found to have increasing abdominal pain and an increasing white blood cell count. He undergoes a CT scan that shows a 5 by 4 by 3 centimeter defined intra-abdominal fluid collection near the anastomosis. What is the next step in management? A, start Cipro and flagyl. B, place a percutaneous drain. C, return to the operating room and create a new primary anastomosis. D, return to the operating room and perform open drainage of the fluid collection. Or E, return to the operating room and create an endoleostomy. Good, so that is the correct answer, place a percutaneous drainage. And so when you look at this, the percutaneous drainage is the least invasive option and provides an excellent source of control. I think if the infection were more generalized throughout the abdomen or if the percutaneous drain failed, then you can discuss surgical intervention. Antibiotics are part of the treatment, but source control really must be obtained to clear the infection. I don't think at this point you need to go after redoing the anastomosis due to the infected environment, and you'd still be at risk for having an additional leak afterwards. If you did have to go in for an operation, you just want to make sure that you address the cause of the abscess and also take into consideration the need for either a temporary loop ileostomy or an endoleostomy to allow for the infection to clear before making a new anastomosis. All right, folks. Here. Just trying to bring up the next slide. You seem to be having some poll everywhere issues, but give us 1 second. All right, sorry about that. So this question, 64-year-old woman with extensive surgical history, including a cholecystectomy, appendectomy, ventral hernia repair, cesarean section, and hysterectomy, presents with abdominal pain, nausea, and vomiting. She reports that she has not passed flatus or had a bowel movement, and a CT scan with oral contrast reveals a partial bowel obstruction. What is the appropriate next step in the patient's management? A, emergent surgical intervention. B, place of a nasogastric tube. C, emergent EGD. D, flexible sigmoidoscopy. Or E, KUB study. So good. Placement of a nasogastric tube. So I think this one makes pretty clear sense. The need for emergent surgical intervention may be considered if we had some additional information that she was hemodynamically unstable or tachycardic or concerned for perforation. KUB is not wrong, but I think in this day and age, she's already had her CT scan, so KUB is not really going to add that much, and so nasogastric tube makes the most sense as a first-line therapy for her. The next question, a 68-year-old man with a history of hypertension and hepatocellular carcinoma status post-liver transplant 5 years ago presents to the emergency department with 2 days of persistent abdominal pain. On examination, he is afebrile and does not exhibit peritoneal signs. Labs are obtained including a CBC, a basic metabolic panel, liver function test, amylase, and lipase. An abdominal x-ray is also ordered. What else should be included in the patient's initial workup? A, CT abdomen pelvis with PO and IV contrast. B, CT abdomen pelvis with PO contrast and no IV contrast. C, urinalysis. D, liver biopsy. Or E, alpha-fetoprotein level. Interesting. So good mix of answers. So what the question wants you to answer is C, urinalysis. And the rationale behind that is they gave you the history that he's status post-liver transplant, which means he's going to be on some form of immunosuppressant. And so you have to take all these things into consideration. He may have a milder presentation with being immunosuppressed in other patients. He's had the lab values, which makes a lot of sense, and the urinalysis should be part of that. I think a CT scan with contrast is perfectly reasonable in this patient, but I think what the key thing is the initial workup. It's one of those kind of key one-word things that they really want you to kind of answer what they have to say, but I think that's where they're trying to get you going. The next question is a 25-year-old woman presents to the emergency department with intense left lower quadrant abdominal pain and nausea. She says that the pain began several days ago as colicky pain. However, over the past several hours, the intensity has become more severe. She has vaginal bleeding currently and says that her last menstrual period was 6 weeks ago. Surgical history includes 2 cesarean sections and a tubal ligation. What is the most likely diagnosis? A, small bowel obstruction. B, appendicitis. C, ectopic pregnancy. D, diverticulitis. Or E, ovarian torsion. This is an important thing because you probably will get 1 or 2 questions on gynecology on the ABSITE, and so it's always good to at least review some of these leading into it. So good. Ectopic pregnancy is the correct answer. And I think the important thing to take into consideration here is they do say that she's had a tubal ligation, but just undergoing a tubal ligation does not rule out ectopic pregnancy, as approximately 1/3 of pregnancies in women who have had previously undergone tubal ligation are ectopic. It's the most common cause of maternal death in the first trimester after pregnancy and account for approximately 9% of all pregnancy-related deaths. Risk factors for prior ectopic pregnancy, or risk factors include prior ectopic pregnancy, previous infection with chlamydia, a pelvic inflammatory disease, increased age, smoking, and prior tubal surgery. Next question, the 56-year-old man with no past medical or surgical history complains of mild abdominal pain in the right lower quadrant for 2 months. On examination, there's a small area that is tender to palpation, but no bulge is present. Workup includes a CT scan, which reveals a Spigelian hernia that is 2 centimeters in diameter. What is the next step in management? A, surgical repair of the hernia. B, watchful waiting with reevaluation if the patient develops more severe symptoms. C, encourage lifestyle changes such as weight loss and smoking cessation. D, colonoscopy. Or E, EGD. So good. Surgical repair of the history or of the hernia certainly makes the most sense. I think C is certainly something that we encourage to all patients before undergoing elective hernia repair, specifically weight loss and smoking cessation, as they increase the risk for complications after hernia repair. But they don't give you any of that history in the stem, and so that wouldn't be the appropriate answer for this question, but certainly something you should take into consideration if they had given you that information in this patient. The next question is a 35-year-old male who presents with Crohn's disease to the emergency department with complaints of diarrhea, left lower quadrant pain, fevers, and jaundice. He has a low-grade temperature but is hemodynamically stable and without peritoneal signs. A CT scan is obtained that demonstrates inflammation of the terminal ileum with associated iliosigmoid fistula and a 7-centimeter right-sided liver abscess. The treatment for this patient would include A, broad-spectrum antibiotics with operative resection of the terminal ileum and sigmoid colon, and operative drainage of the liver abscess, B, broad-spectrum antibiotics and IV steroids, C, broad-spectrum antibiotics and percutaneous drainage of the liver abscess, D, mebendazole, or E, broad-spectrum antibiotics and ileocystectomy during this admission. All right, so C is the correct answer, broad-spectrum antibiotics and percutaneous drainage of the liver abscess. So when you take this into consideration, infection control with broad-spectrum antibiotics and drainage certainly makes the most sense and decreases the risk of sepsis and improves his odds of being successful with conservative management. Empiric antibiotics should be selected to cover the microbes that are typically responsible. Broad-spectrum antibiotics with operative resection is incorrect because at this point he certainly doesn't need to go for resection and hopefully can get by with minimally invasive approaches. Attempting medical management to allow for delayed operative intervention is appropriate to decrease post-operative morbidity and the extent of resection. A 34-year-old woman with Crohn's disease presents with fevers, abdominal pain, and emesis. Her white blood cell count is 17,000, and a CT scan shows a multiple large interloop abscess. What is the best course of management? A, perform surgical drainage of the abscess. B, place a percutaneous drain through the overlying bowel to drain the abscess. C, start broad-spectrum intravenous antibiotics and continue to monitor. D, decrease current steroid dose and continue to monitor, or E, start oral antibiotics and continue to monitor. So perform surgical drainage of the abscess is the correct answer. I think a couple things to take into consideration here. They talk about in the stem that it's interloop, and so I think that kind of rules out the ability to perform a percutaneous drainage due to the overlying bowel of what's going on. Starting broad-spectrum antibiotics is incorrect because she really needs to obtain source control. She's got a white blood cell count of 17. They don't really give you a size, but they say multiple large interloop abscesses, and so I think that's what's going to push you towards proceeding with operative intervention rather than just antibiotics alone. Decreased intersteroids will certainly help fight the infection, but again, you still need to get source control. You know, I think a couple things to take into consideration. We'll just briefly talk about some general ABSITE study strategies. You know, everybody has a different way to study, and I think it's important for you to kind of pick the strategy that works best for you. I know a lot of people like to read different books and different things like that, but I find the most useful thing is to do question banks. And I kind of pick my questions based off of not the areas that I know the best, but rather the areas that I tend to do the worst at. So as I go through my question bank scenarios, I'll usually kind of look at which ones that I get wrong and use those to help guide which areas that I spend more time reading and studying on, rather than just kind of going through the ones that I get right. It's also important, rather than just generally answering lots of questions, to take a few minutes and actually look over what the answers are and why those answers are, as that will ultimately give you some more information, because you're not going to find stems that are be exactly the same as what you get as you go through the studies. A 30-year-old woman presents with intractable pain secondary to endometriosis, comes to your clinic after 2 years of failed medical management. You identify multiple isolated pelvic implants during exploratory laparoscopy. What is the appropriate management? A, hysterectomy with oophorectomy. B, hysterectomy without oophorectomy. C, ablation of the endometrial implants. D, direct laparoscopic ablation of steroid solution. Or E, imbricate the peritoneum over each lesion. So correct. C is the right answer, ablation of the endometrial implant. So this is a woman is of childbearing age, so conservative surgical management of these implants is warranted. This includes either ablation or resection with sharp dissection. The risk for needing recurrent operation is pretty high, 58% with conservative ablation and 18% with hysterectomy without oophorectomy and 8% with hysterectomy plus oophorectomy. Steroids do not have any role in the management, but I think the key thing is that she's of childbearing age.
We noticed there's a little conversation about the role of OB questions in the ABSITE, and I know it's a little outside of the kind of core general surgery, but keeping in mind that the American Board of Surgery, of which the ABSITE is focused on, covers not only the bread and butter general surgery, but also for general surgeons, especially those in the community. You may be expected to do urologic procedures, gynecologic procedures, even some orthopedic procedures. So it is important to review those topics, as you'll get a mix of those on the ABSITE as well.
So the next question is a 55-year-old woman with borderline resectable pancreatic cancer is taken to the operating room for diagnostic laparoscopy. Evaluation of the liver, bowel, and abdominal wall shows no signs of malignancy. Pelvic washings are sent for histology. What is the best next step? A, mobilize the hepatic flexure and evaluate for retroperitoneal implants. B, divide the gastrocolic omentum to access the lesser sac and evaluate for malignancy. C, take random hepatic needle biopsies representative of each liver segment. D, perform laparoscopic ultrasound of the gastric surface. Or E, no further exploration is needed. So correct, B is the right answer. The direct inspection of the pancreas and the peripancreatic lymph node burden must be completed. Furthermore, washings in a lesser sac can be performed to allow for cytologic evaluation. Laparoscopic ultrasound can be used as an adjunct to assess patency of nearby vessels, stenosis of the pancreatic duct, and to guide lymph node biopsy. Next question is a 90-year-old woman who's brought in from a nursing facility with abdominal pain, nausea, and vomiting. On exam, she is cachectic with a softly distended abdomen that is mildly tentative palpation diffusely. CT reveals a small bowel obstruction from an incarcerated obturator hernia. At exploration, you find an incarcerated segment of ischemic ileum that is difficult to reduce from the obturator hernia defect. What is the most appropriate next step in operative management? A, perform an ileocholic bypass of the obstructive segment. B, adduct and immediately rotate the thigh to aid with manual hernia reduction. C, incise the obturator membrane to help reduce the hernia. D, divide the inguinal ligament to improve exposure. Or E, make an enterotomy to decompress the incarcerated segment to allow reduction. One of those hernia types that we talk about a lot but don't see very frequently in clinical practice. But it's one of those things that when somebody shows up, you really want to know how the right way to manage them. So C is the correct answer, incise the obturator membrane to help reduce the hernia. So I think what's really important here for any kind of incarcerated hernia that you see, whether it's in the groin or in the abdomen or anything like that, if you're concerned that there's incarcerated bowel, you obviously have to reduce it. And if you're having trouble reducing it, given the size of the hernia defect and that defect itself and its constraints, then you need to find a way to make that defect larger to help facilitate bowel reduction. For this case, it's important to consider incising the obturator membrane to help reduce the hernia. These can be really difficult to diagnose, but something that you certainly want to keep in the back of your mind in somebody who presents with a bowel obstruction with no other clear source of what's going on. Next question. One day following laparoscopic repair of a Spigelian hernia, a 40-year-old man presents with increasing abdominal pain, fever, and vomiting. On examination, he's tachycardic with a distended abdomen that is diffusely tender to palpation. He undergoes a CT scan that demonstrates diffusely dilated small bowel with a significant amount of free fluid and pneumoperitoneum. What is the most appropriate next step? A, initiation of broad-spectrum intravenous antibiotics with a monitoring of response. B, urgent exploratory laparoscopy or laparotomy. C, percutaneous sampling of the fluid by interventional radiology. D, discharge home with antiemetics and pain medication. E, placement of a nasogastric tube and admission for serial abdominal examination. All right, everybody, we got to get a 100% answer just like Dr. Awad had, so I want everybody to really focus in on this one.
No pressure, no pressure.
Close. Not quite. So I think what you have to keep in mind is this is a patient who had a laparoscopic repair of a Spigelian hernia just yesterday, and he comes in and he's sick. He's got a fever, he's vomiting, he's tachycardic, and he's got a significant amount of free fluid. This is a missed enterotomy until proven otherwise, and I would say that this is certainly a missed enterotomy that you need to take into consideration. So this gentleman needs to be explored, whether it's via laparoscopy or laparotomy. I think this one should be pretty clear-cut. So next question is a 65-year-old woman with a past medical history notable for perforated diverticulitis, status post-sigmoid colectomy, Hartmann's pouch, and an end colostomy, is admitted with a partial small bowel obstruction associated with a large peristomal hernia. The obstruction resolves quickly with non-operative management. What is the most appropriate next step? A, proceed with peristomal hernia repair with mesh on this admission. B, discharge home with follow-up by her primary care physician for the small bowel obstruction. C, plan for outpatient interval peristomal hernia repair. D, ask nutrition to educate the patient about a low-residue diet. Or E, evaluate the patient for possible colostomy reversal by obtaining prior operative and endoscopy reports. All right, let's see how we did. So good. E, A, B, C, D. E is the correct answer. I think the first thing when I teach the residents, and I see a lot of peristomal hernias in the clinic, the first thing I tell them, the first question you should ask any patient who comes in with a peristomal hernia is, can we reverse your stoma? And I think that should really be question number one for any patient. This patient resolved, and so they're now talking about kind of what's your management of peristomal hernias. In an ideal situation, you'd be able to reverse their stoma, and that would give you much better odds of having a long-term successful hernia repair if possible. So I think this one is the first option should be, can you get your hernia, your stoma reversed, and then start to talk about hernia repairs down the road. Next question, a 45-year-old man is seen in your office for evaluation of an incisional hernia. His history is significant for a motor vehicle accident for which he underwent an open right nephrectomy, as well as tobacco dependence. On examination, he is a well-appearing, obese patient with a large reducible hernia along the length of a right flank incision. What do you recommend? A, weight loss and cessation of tobacco use with bariatric surgery referral if appropriate before consideration of hernia repair. B, robotic laparoscopic hernia repair with mesh because this minimizes pain and complications. C, open repair with component separation and primary fascial closure because this will give the best cosmetic result. D, expectant management with a binder and limiting heavy lifting because the recurrence rate of this hernia is a prohibitive risk. Or E, laparoscopic assisted hernia repair with sandwich mesh placement because this will give the most durable repair. Lots of things to consider in this stem for sure. So good. So a couple of things. They don't give you the BMI for this patient, but they tell you that he is obese, and they tell you that he's actively smoking. So for me, those are two non-negotiable factors to consider really in any hernia repair, whether it's open, laparoscopic, or robotic, is to try to optimize the patient before considering hernia repair. As far as what the specific technique that you approach is, these are difficult hernias along the flank because there's often not only a component of a true defect or hole in the muscle, but they also have some atrophy just related to the style of incision that they undergo. So this question really isn't trying to get you to pick the right technique because, again, there's going to be a tremendous variability in what people would recommend for this patient, but really to try to get you to pick up on the use of his tobacco and his obesity and try to get him optimized for surgery before proceeding. Next question is a 76-year-old woman who presents with nausea, vomiting, and abdominal and groin pain. On examination, she appears thin and frail. The abdomen is distended. You notice a tender bulge is present in the right groin. Her groin pain is improved with thigh flexion. Laboratory data shows a leukocytosis. What is the next step? A, urgent exploration. B, admission to the hospital ward with nasogastric tube decompression and fluids. C, CT scan to confirm your diagnosis. Or D, reduction of the groin bulge and discharge home from the emergency department. So I think for the sake of time, we'll make this our last question. So everybody give it your all. Good. So urgent exploration really makes the most sense. She's got everything that you would be concerned of. She's got nausea, vomiting, abdominal and localized pain. She's got a tender bulge that's present in the right groin. I think you need to really consider urgent intervention for this patient rather than anything else. Sure, you can get a CT scan, and oftentimes these patients will have a CT scan before you see them, but she has enough clinical factors in this stem to consider going to the operating room. I think reduction of the groin bulge and discharge from the emergency department is certainly, in my mind, not an appropriate course to take because at this point you haven't evaluated the viability of the valve, and even if you can get something reduced, there are certainly scenarios where patients will represent several days later with ischemia that wasn't recognized after their bowel was reduced and they were sent home.
All right. Well, Dr. Blatnik, thank you very much for that amazing review of general surgery, abdomen, hernia, and spleen. We're going to go ahead and move on to our next section here, which is going to be our colon and anorectal disease. I'm going to bring on Dr. Amber Traugott, who's an esteemed colleague, surgical educator, and colorectal surgeon at Ohio State University. Dr. Traugott, are you there?
Yes, I am. Hello.
Great. I'm going to just bring up our next slide here while we're introducing you. You can introduce yourself while we get that going.
Well, hello. As Dr. Awad said, I'm Amber Traugott. I'm a colorectal surgeon on faculty at The Ohio State University, and I'll be going over some questions on colorectal and anorectal disease today. So why don't we go to the first one? All right, so the first patient is a 36-year-old female with a 10-year history of Crohn's disease who presents with severe perianal disease that has been difficult to control. The patient has multiple complex perianal fistulas refractory to medical management, including infliximab and ceton placement. Well, there you go. MRI shows multiple fistulas passing through the sphincter. Which of the following is the optimal procedure for this patient? And your options are segmental colectomy, total proctocolectomy, subtotal colectomy with ileostomy, APR, or a low Hartmann procedure. And while the clock's ticking down, I think it's also worth considering how our management of Crohn's disease and UC are different as we progress through the rest of these questions. So the answer is APR. And the reason for this is that the patient described in the question stem really has perianal disease, and although it's not explicitly stated, you can infer that she doesn't have pancolitis. So for Crohn's disease, we can consider segmental colectomy or proctectomy to try to remove the medically refractory areas and preserve healthy bowel as much as possible. And in this case, the patient's failed all medical management. You could really just do a proctectomy with an end colostomy, which is an APR. So next patient is a 43-year-old male with UC who presents to the ED with a day of diarrhea with slightly bloody streaks, which he's had 7 episodes. A fever of 38.6, heart rate of 114, a hemoglobin of 7.5, which is anemic. His baseline is 11. He's negative for C. diff infection, and CT abdomen pelvis with contrast shows pancolitis without pneumoperitoneum. He was started on antimicrobial agents and high-dose IV methylprednisolone, but develops worsening abdominal pain over the next 48 hours. What is the best surgical option for this patient? So A is iliopouch anal anastomosis. B is total abdominal colectomy with ileostomy. C is a coke pouch. D is colectomy with iliorectal anastomosis. And E is a right hemicolectomy with a colostomy. And we'll let you get your votes in. Okay, and our correct answer is B. So most of you got this correct. So it's worth kind of noting for the folks that chose other options. In a patient with UC, acutely requiring surgery, who is having some clinical deterioration, perhaps you want to do a total abdominal colectomy with end ileostomy and preserve their future reconstructive options. This would allow the patient to wean off the steroids and to recover from their acute inflammatory process. And then later they could be offered an iliopouch anal anastomosis as a staged procedure. In general, we don't perform a colectomy with an iliorectal anastomosis for ulcerative colitis, although it can be considered for other colon diseases that maybe require a total abdominal colectomy, such as polyposis with rectal sparing. All right. Next patient is 2 years after a sigmoid colectomy for a stage 3 T3N1M0 carcinoma of the colon. A 55-year-old man has a solid, let's see if I can find it. I can't read behind there. 2-centimeter metastasis in the periphery of the right lobe of the liver. The most appropriate management is A is infusion of 5-FU via the hepatic artery. B is wedge resection of the lesion. C is a right hepatic lobectomy. D is ligation of the right hepatic artery. And E is external beam radiation therapy. And time's up. So good, most of you got this one right. So wedge resection of the lesion is correct. In a case like this, characteristic imaging findings are usually sufficient with that history to make the diagnosis of metastases, and the goal is to resect metastases, but that does not necessarily need to be an anatomic resection if the lesions are small and can be removed in that way. All right, a 50-year-old man failed to open properly. So I'll go over the question a little bit while they're trying to pull it up. It's a 50-year-old man who previously underwent a laparoscopic-assisted sigmoid resection for diverticulitis 5 years ago, who now comes in with left lower quadrant pain and a leukocyte count of 18,000. He has a CT scan done, and that's consistent with sigmoid diverticulitis. What is the most likely reason he has recurrent diverticulitis? So A is young age, B is colosigmoid anastomosis, C is gender, D is laparoscopic approach, or E is adenocarcinoma. Right, so most of you got this correct. So in this patient, the really significant determinant of whether he would get recurrent diverticulitis is where the anastomosis was made. Retention of a portion of the sigmoid is associated with a significantly higher risk of recurrent diverticulitis, and this is why we always tell our trainees to make sure that you're making the anastomosis at the top of the rectum, which you identify by the confluence of the tinea coli. You want it to be soft and pliable tissue that doesn't appear to have that thickening associated with prior diverticulitis. Next is a 64-year-old man with rectal cancer, 12 centimeters from the anal verge, is in your clinic for preoperative evaluation. On the staging CT of the abdomen and pelvis, a 4-centimeter abdominal aortic aneurysm is incidentally identified. What is the appropriate management for this patient? A, management of the rectal cancer and observation of the AAA. B, open AAA repair followed by management of the rectal cancer. C, synchronous operative intervention for the rectal cancer and the AAA, or D, endovascular repair of the AAA and resection of the rectal cancer 2 weeks later. Okay, good. Almost everyone got that correct. So yes, you would manage this patient's rectal cancer and observe the AAA as you would in any 4-centimeter asymptomatic AAA. Obviously, if the patient has a larger aneurysm that is more likely to rupture, that may require repair prior to cancer resection. And so that decision should be made in a multidisciplinary fashion with vascular and the oncologic surgery team, colorectal team, whoever's doing the rectal cancer management. All right, a 65-year-old male presented to the emergency department with sudden onset abdominal pain and bloody diarrhea. He is diagnosed with ischemic colitis. He was hospitalized and treated with IV fluids, bowel rest, and broad-spectrum antibiotics. His symptoms resolve, and he is discharged to home tolerating a diet after 6 days. 2 months later, he returns, complaining of 2 weeks of intermittent crampy abdominal pain and constipation alternating with diarrhea. What is the likely diagnosis? A, C. diff colitis. B, recurrent ischemic colitis. C, colonic stricture. D, small bowel obstruction. Or E, irritable bowel syndrome. All right. So the correct answer is C. So let's talk about that a little bit. So I'm sure that many of you chose other options because the symptoms that the patient's having are, by themselves not particularly specific. However, I think for the purposes of testing, one would expect C. diff colitis to produce just diarrhea and not alternating constipation and diarrhea. Although if someone were developing an ileus, then you would also expect them to look more clinically ill or to have some signs of sepsis described. Recurrent ischemic colitis would likely produce bloody diarrhea similar to what his original presentation looked like. A small bowel obstruction would tend to produce, more obstipation, distension, nausea, vomiting. And while the symptoms that are described are symptoms of irritable bowel syndrome, that's not the most likely diagnosis in a patient who has a history of ischemic colitis, who can develop a stricture secondary to the ischemia. And that's why that answer is correct. All right. A 65-year-old woman presents to your office complaining of incontinence of her chronically loose stools and gas. She has had 3 vaginal deliveries. On physical exam, she has moderate rectal tone and a thin perineal body. Endorectal ultrasound reveals an intact sphincter mechanism. Defecography and colonoscopy identified no other abnormalities. What is your recommendation? A, high-fiber diet. B, sphincteroplasty. C, sacral nerve stimulation. D, artificial bowel sphincter. Or E, end colostomy. And the answer, let's see what everyone chose, that's correct. So high fiber diet, most of you got. The next most chosen answer was sacral nerve stimulation. And while it is true that sacral nerve stimulation is a very effective treatment for incontinence, it's not usually the first line treatment. First, we focus on management of stool consistency. And so in a patient who has chronically loose stools or diarrhea, our first goal is to try to bulk the stool, treat diarrhea, and make sure that we have ruled out any other causes that a patient's bowel habits might be deranged. And so that's why a high-fiber diet is the correct answer here. A 36-year-old man presents for follow-up after excision of an internal anal lesion. The pathology showed a condyloma with anal intraepithelial neoplasia 1. The most appropriate next step in his care should include which of the following? A, no further evaluation is necessary. B, testing for HIV infection. C, anal pap smear testing. Or D, returning to the operating room for wide local excision of the dysplastic site. And the correct answer is B, so testing for HIV infection. So let's talk about why that is correct. So in a patient with anal condyloma and low-grade dysplasia, which is what AIN1 is, your further management is going to be guided by by the patient's risk of recurrence or their potential risk of harboring high-grade dysplasia associated with that. So no further evaluation is incorrect because those issues need to be clarified before you can give the patient appropriate guidance on surveillance and their prognosis. Anal pap smear testing is done as a screening tool for patients who are already known to be high risk, who are not known to have dysplasia. So that's incorrect in this patient because he's not known to have risk factors that would require screening, and at this point he has a diagnosis of dysplasia, so he's going to require some sort of additional surveillance once his risk profile is known. And returning to the operating room for wide local excision is not appropriate because this is low-grade dysplasia associated with a condyloma, and that would need to have progression to high-grade dysplasia and squamous cell carcinoma in situ before it would have an indication for a wide local excision. So that's why HIV testing is indicated. A 45-year-old male presents with rectal pain without any evidence of external erythema, induration, or fluctuance. Digital rectal exam is notable for bulging of the anal canal that is painful to palpation. Appropriate management includes A posterior midline incision for drainage of a horseshoe abscess, B, external drainage via incision in the ischioanal fossa, C, internal drainage with division of the internal sphincter along the length of fluctuance, D, external drainage via a catheter placement, or E, internal drainage via an incision in the supralevator position. Fistula questions are very popular on the ABSITE and the boards, and so this is a good one to kind of review some of those principles. Okay, so internal drainage with division of the internal sphincter along the length of fluctuance is correct. So the reason for this is that this question stem is describing exam findings to you of an intersphincteric abscess. So you know it's in the anal canal, so it is at the level of the sphincter complex, and it's bulging into the anal canal rather than being external to the external anal sphincter. And so that tells you that you're dealing with an intersphincteric process. So that immediately rules out the first answer, posterior midline incision, because that's what you would do for an abscess in the deep postanal space. External drainage via incision in the ischioanal fossa would require you to cross the external anal sphincter in order to achieve drainage of this abscess. And so if the patient has an internal fistula opening, you're going to create a transsphincteric fistula by doing that. Similar for external drainage via a catheter. And then internal drainage via supralevator position. Now, this abscess is in the anal canal, so it's not that high. All right, a 35-year-old male has a chronic posterior midline anal fissure. What surgical treatment would you recommend? A, anal dilatation, B, fissure resection and closure of a residual defect, C, endorectal advancement flap, D, lateral internal sphincterotomy, or E, posterior internal sphincterotomy. Okay, good. Most of you got that one correct. Lateral internal sphincterotomy is the recommended surgical treatment for fissures that have, particularly those that have failed other more conservative approaches. A 56-year-old HIV-positive male has a long history of pain with defecation and intermittent bleeding in the toilet bowl. On exam, he has a chronic appearing ulcer to the left of the posterior midline with an associated sentinel tag. You do not appreciate any masses or other abnormalities on the perianal skin. What treatment would you recommend? So A is exam under anesthesia and biopsy of the ulcer. B is topical nitroglycerin. C is anal dilatation. D is endorectal advancement flap, and E is injection of botulinum toxin. And hopefully you all can get your votes in. Okay, good. Looks like most everyone understands that HIV-positive patients are at a much higher risk for atypical causes of fissure and squamous cell carcinoma. All right, a 60-year-old man has rectal pain and a tender 2-centimeter mass at the anal canal. Sigmoidoscopy shows normal rectosigmoid mucosa. Biopsy of the mass shows a squamous cell carcinoma of the anus. The most appropriate management is which of the following? A, radiation plus chemotherapy. B, circumferential anoplasty with coloanal anastomosis. C, abdominal perineal resection. D, chemotherapy only. Or E, local excision with a YV-plasty. All right, so that's correct. Radiation plus chemotherapy or a modified NIGRO protocol is standard treatment for anal squamous cell carcinoma unless the patient has a contraindication. Local excision does not play a role for an invasive squamous cell carcinoma. Next is a 62-year-old man with a T2N0M0 squamous cell carcinoma of the anal canal who is treated per modified NIGRO protocol, which is listed there. He presents to the clinic 8 weeks after treatment, and on physical examination is noted to have residual tumor. What is the next best step? A, abdominal perineal resection. B, an additional 14 gray of radiation. C, wide local excision. D, systemic chemotherapy with 5-FU and cisplatin, or E, observation with repeat physical exam at 6 to 8 week intervals. All right, so let's talk about this a little bit. So patients who are treated with modified NIGRO protocol can have an ongoing response to that treatment for up to 6 months after their treatment has finished. And so at 8 weeks, if they still have residual tumor, that doesn't necessarily represent a treatment failure, but it needs to be continued to be monitored because you want to make sure that that lesion is continuing to regress over time. And the typical interval is about every 6 to 8 weeks. If the patient should reach a point at 6 months where there's still residual tumor present, or if it starts to increase in size, that's when you consider them to have failed that treatment and they would require a salvage APR at that point. Wide local excision doesn't play a role for anal canal squamous cell carcinomas. It has a role for anal margin squamous cell, which is outside of the intersphincteric groove. So those are tumors that are away from the sphincter complex. And additional boost radiation isn't typically done except on a case-by-case basis. All right, a 54-year-old man presents to your clinic 48 hours after rubber band ligation of internal hemorrhoids. He is complaining of inability to void and worsening anal pain. Vital signs are temperature of 38.7, heart rate of 88 beats per minute, blood pressure 130/85, and respiratory rate of 18. The next step in management of this patient is A, removal of the band with a number 11 scalpel blade. B, topical lidocaine, C, Foley catheter and increases pain medications, D, broad-spectrum antibiotic coverage with prompt evaluation and drainage of perianal abscess, and E, warm sitz baths and stool softeners. All right, so broad-spectrum antibiotic coverage and an exam under anesthesia with probable debridement and IND is the answer. And the clues that you're given there are urinary retention, worsening pain after a procedure that's supposed to be painless, and you know, he has, you know, relatively normal vitals, but these other symptoms are not typical after 48 hours after band ligation. Removal of the band would be appropriate if you placed the band in the clinic and you ended up too close to the dentate line and the patient immediately had pain. That's the situation where you would remove the band in that way. And yes, a Foley catheter is probably indicated. However, the patient needs additional evaluation. And sitz baths and stool softeners are not sufficient or appropriate here.
Traugott, I want to thank you very much for that excellent review of colorectal and anal disease. That was wonderful. Thank you again. We're going to go ahead and move on to our next section, which is small intestine biliary disease and flexible endoscopy. Dr. Adnan Alseidi, who is a great colleague and friend, a hepatobiliary surgeon at Virginia Mason in Seattle, is going to be presenting that. He's also one of the esteemed surgical educators in the nation, and we're very lucky to have him here. By the way, the questions we picked really from SCORE are either ones that are frequently asked or questions that are often wrong, or people get them often wrong. So that's kind of gives you a sense of the questions that we pulled here. Dr. Alseidi, welcome and thank you for joining us.
Thank you, Mike, and thanks. You're too kind with that introduction. Can you guys hear me okay?
Yes.
Okay. So it's certainly a pleasure to be here. I just want to remind everybody, please write your comments, any questions on the side. If you have them, we'll get to them promptly. We're going to go quickly on some of them and take our time in some of them. I also want to encourage everybody that's interested in any of the biliary topics like we're going to discuss today, or even small bowel or MIS. A lot of this material is covered very succinctly in stages, and would love to see you guys all there. It's one of the more friendly organizations, especially for people starting out their career, so hopefully we'll see you guys there. So let's get started. Again, write questions on the side, and hopefully we'll answer them as we go on. The first question is, a 54-year-old woman presents with lower abdominal pain of acute onset. She has a rigid abdomen with peritonitis. An upright chest X-ray shows free air. She's taken urgently to the operating room. Upon exploration, a large mass is identified in the distal ileum and is in an obvious site of perforation. Which of the following is the most likely diagnosis? Neuroendocrine tumor, primary adenocarcinoma, small bowel lymphoma, metastatic melanoma, and metastatic adenocarcinoma of the stomach. Okay, so as Dr. Awad said, this is we choose these questions for a reason, and this is the reason. And so the correct answer, as you can see, is lymphoma. Now, why is that? So neuroendocrine tumors are typically present with either symptomatic, biochemically symptomatic, if they are producing biochemical activity, or obstruction. They don't typically present with perforation. Adenocarcinoma typically presents with obstruction, and they're usually small. Melanoma typically presents with either bleeding or interception. And then obviously metastatic adenocarcinoma, in this case it doesn't fit. You usually would have significant metastatic disease if you're basically presenting with metastatic stomach cancer, but certainly wouldn't cause a perforation in the terminal ileum. Lymphoma is the one that most likely presents with perforation and also has this usually presenting with a large mass, and that's why it fits this way. It's a 60-year-old female with IBS, presents to the emergency room with nausea, vomiting, abdominal pain for 4 days. Her abdomen is distended and tympanic, and she has rebound tenderness and a fever. Exploratory laparotomy is performed, and the cause of obstruction identified as an annular mass in the proximal jejunum. The area is resected with a wedge of mesentery. Pathology shows 5-centimeter adenocarcinoma with no metastasis in 6 lymph nodes which are recovered. The proximal margin shows a focus of residual adenocarcinoma. Which of the following factors is associated with a poor prognosis for this patient? The answers are size of 5 centimeters or 5 centimeters, history of IBS, presenting with obstruction, retrieval of 6 lymph nodes, and then positive margin. And feel free to ask questions about any of these questions as we go on, and we'll answer them. Just type in your question. Yeah, so the majority got that correctly. Just for clarification, size and lymph nodes have been shown to be low lymph node harvest have been shown to be indicators of poor prognosis, but not necessarily with small bowel adenocarcinoma. In fact, nobody really knows what number of lymph nodes is ideal for a small bowel. So that doesn't apply here. Positive margin is always a bad thing in every adenocarcinoma, no matter what. So that's always a safe bet. So next question. A healthy 45-year-old woman with FAP is discovered to have an ulcerated 3-centimeter periampullary mass, which biopsy shows to be a villous adenoma with high-grade atypia. Which is your approach to the management of this patient? Observation with repeat upper endoscopy in 6 months, endoscopic mucosal resection, pancreatic duodenectomy, ablative therapy, and local excision. Okay, so three-quarters got it correctly, so that's good. Let's review some of the other answers. So observation with repeat endoscopy and endoscopic mucosal resection would be okay if this was low-grade dysplasia. With high-grade dysplasia, there's a very high chance that this actually presents with cancer. And for that reason, a pancreatic duodenectomy, which means you're treating it like cancer, is the right answer. Ablative therapy and local excision is not ideal for cancer or for high risk, in the presence of high risk for adenocarcinoma. So our next patient is a 50-year-old woman presents with 3 days of nausea, vomiting, and abdominal pain. She has no prior history of surgery. CT scan shows interception in the mid-jejunum. The patient undergoes exploration and resection of a portion of the jejunum with primary anastomosis. No other abnormalities are noted at the time of exploration. Final pathology shows mucosa-associated lymphoid tissue within the bowel wall, and the resection margins show normal small bowel. Which of the following is the next step in management? A, observation. Next one is administration of rituximab and fluoridine and mixotrone and dexamethasone. Next is administration of cyclophosphamide hydroxyurbicin and vincristine and prednisone, which is CHOP. Next is primary bowel radiation and radiation of the retroperitoneal lymph nodes. And next is oral course of PPI, amoxicillin, and clindamycin. Okay, so what most people chose, the answer obviously is observation, and what most people chose is the last one, and that would be the treatment for a mucosal-associated lymphoid tissue, which is a MALT, if it's found in the stomach. In the small bowel, typically the treatment, because that's the treatment for H. pylori. However, in the small bowel, that typically is not necessary, and resection is all you need. Obviously, CHOP is the treatment for Hodgkin's lymphoma, excuse me, which is not the case here. And that would be the third answer that 11 people answered. But in general, I think, the key here is it in stomach or in the small bowel? In the stomach, treatment of H. pylori is indicated. If it's in the small bowel, resection is all you need. There's a question here from Carl. It says, are we assuming high-grade atypia is the same as dysplasia? In general, the answer is yes. Atypia and dysplasia are used interchangeably. In the pancreas and the small bowel, it used to also high-grade dysplasia, high-grade atypia, and carcinoma in situ all used to mean the same. In the new criteria, we don't use carcinoma in situ anymore. And typically, we should say high-grade dysplasia, not atypia, but they're both equivalent. Thanks for the question. So the next question is, 72-year-old woman with no prior history of surgery presents with abdominal pain, facial flushing, and high-grade small bowel obstruction. She's taken for a ciliotomy and found to have a mass in the ileum invading into the retroperitoneum that is causing the obstruction. She also has a 2-centimeter lesion in segment 3 of the liver. What is the most appropriate management of this condition? A, en bloc small bowel resection. The next number is en bloc small bowel resection and liver resection with negative margins. Next is en bloc small bowel resection and liver transplantation. Next is en bloc small bowel resection followed by somatostatin and Alnog. And the last one is palliative gastrostomy. Okay, so the correct answer is B, which is en bloc small bowel resection with liver resection with negative margins. Just to be clear here, what we're talking about is neuroendocrine tumor or carcinoid with metastasis to the liver. In that situation, if you can clear the liver, then you should resect the liver, even if it's more than one lesion. It doesn't matter how many lesions. The key is, can you clear render the patient NED. In this case, it looks like we can, so that's indicated. In situations where there's significant liver disease and the patient has the primary out, and for 6 to 9 months there's no evidence of any progressive disease, transplantation may also be indicated, but that's obviously not the case here. And then metastatic analog would be indicated in situations where surgical clearance is not an option or the patient is symptomatic with respect to biochemically symptomatic, which is in this case not correct. So, okay, next question. A 38-year-old man with Crohn's disease for 15 years undergoes laparotomy and resection of a strictured portion of distal ileum. In the area of the stricture, Crohn's disease is confirmed and a 2-centimeter small bowel mucosal neoplasm is noted. Which of the following is the most likely pathologic diagnosis? leiomyoma of the proximal small bowel, carcinoid, hamartomas, adenocarcinoma, non-Hodgkin's lymphoma of the small bowel. There's a question here, is cholecystectomy still recommended if octreotide therapy is anticipated? The answer is yes. The answer, 60 to 80% of patients will develop symptoms, biliary symptoms, on long-acting octreotide, so cholecystectomy is indicated. Okay, 75% of the group got that correctly. Obviously, Crohn's does increase your risk for adenocarcinoma tenfold or so, and so that is the most likely pathologic diagnosis. I'm not quite sure why 20% said non-Hodgkin's lymphoma. Okay. 76-year-old man is being seen in clinic following resection of an obstructed jejunal tumor, 15 centimeters in greatest diameter. Prior to surgery, he is otherwise healthy. The final pathology report shows a 14-centimeter spindle cell neoplasm with presence of KIT mutation CD117. The mutation rate is greater than 10 per high power field. 22 of 22 lymph nodes are negative for tumor. The final diagnosis is just tumor. What is the best recommendation for this patient at this time? And the answers are observation, adjuvant chemo with 5-fluorouracil followed by imitamab for 1 year, adjuvant therapy with imitamab for 1 year, adjuvant therapy with imitamab for 3 or more years, adjuvant therapy with imitamab for 1 year along with radiation therapy. Guest register 1, is it true also for peanuts? The answer is yes, it is true also for peanuts. Okay, so it seems that the confusion here is 1 year or 3 years. The recommendations is 3 years if you're considered a high-risk GIST. In this case, there are two things that make this high risk. One is the size, which is greater than 10 centimeters, and the other is greater than 10 mitotic figures per 50 high power field. So the recommendation is 3 years. So the answer is A, B, C, D, D.
And Dr. Alseidi, is it it's 3 or more years? So is it the case we don't really know kind of the end date on the therapy for those? Is that right?
That's absolutely true. So in patients which are very high risk, based on either margins or then I just resected somebody with 115 mitotic rates per higher power field. We put those patients on indefinitely. So yeah, so we don't actually know the answer how long.
Thank you.
Okay, so we're going to go to the biliary side of things. 60-year-old woman with known gallstones presents to the emergency room with jaundice, fever, chills, and confusion. Blood pressure is 80/40, heart rate is 120, temp is 38.3. You send off stat labs and find that her white blood cell count is 15,000. Creatinine is 2.3, total bilirubin is 5. AST ALT is 230, alk phos is 500. Right upper quadrant ultrasound confirms condylar dilatation with diameter of 15 millimeters throughout most of its extent. What should be your very next step? Emergent PTCD, emergent ERCP, IV fluid resuscitation and broad spectrum antibiotics, and urgent laparoscopic cholecystectomy. So greater than 5 centimeters and greater than 5, for the question on the board there, I assume everybody can read that. For greater than 5 centimeters and 5 mitotic figures, it puts you in medium risk. And then what about neoadjuvant chemo? Yes, neoadjuvant chemo is recommended for patients like this. In this case, that wasn't the question. But yes, in these patients, it's a good idea to start ahead of time to see response. And that is actually a change in the recent criteria. 3/4 got that answered correctly, which is C. IV resuscitation and broad-spectrum antibiotics. Remember that that question is asking for the very next step. There's no doubt that drainage of, this is obviously a picture of cholangitis with Raynaud's, and there's no question that drainage of the biliary system is indicated. However, in patients who are obviously in shock, the first step would be IV antibiotics and broad-spectrum and resuscitation. Okay, so the next question is 40-year-old obese woman who is a mother of 2 children presents to the ER with new onset right upper quadrant pain of 8-hour duration. She reports no fever, nausea, or vomiting. On exam, she does not have right upper quadrant abdominal tenderness or Murphy sign. Her white blood cells count is normal. Ultrasound demonstrates gallstones without gallbladder wall thickening or pericystic fluid. After receiving pain medication, the pain completely subsides. Appropriate management should be admission to the hospital, NPO, antibiotics, and lab chole. Next number is admission to a hospital, NPO, antibiotics, and eventual delayed cholecystectomy 4 to 6 weeks later. The next is prescribing a pain medication discharge from the ER and eventual elective lab chole. And next is HIDA scan and, if negative, abdominal CT scan to confirm or rule out cholecystitis. Margaret, the answer to your question with respect to segmental resections, if you have high-grade dysplasia, you've got to treat that as cancer, as more than 3/4 of those patients will have cancer present. And for that reason, we do not recommend segmental resections. And remember, this was an ampullary adenoma too, so there's no real segmental resection that you can do. You can do local resection, but that's not indicated in high-grade dysplasia. So the answer is correct, which is C. 88% got that correctly. Remember that this is more of a question of resource utilization. I mean, is it necessarily wrong to admit that patient and do a cholecystectomy right then? It's not necessarily harmful, but it's wasteful, and that's why in these patients, the diagnosis is symptomatic cholelithiasis, and for those patients, it is safe to discharge and have them come electively for a laparoscopic cholecystectomy. Okay, I see questions coming in. Keep them coming, and we'll answer them. 32-year-old man presents with a 2-year history of epigastric right upper quadrant pain. The pain occurs whenever he attempts to eat pizza or other fatty foods. He has previously undergone abdominal sonography and was found to have no gallstone, no pericystic fluid, or gallbladder wall thickening. He also has undergone EGD, which was unremarkable. His symptoms persist, and he sought you out as a second opinion. Your next best step is evaluating his pain further. A, repeat abdominal ultrasound. 2 is CT scan. 3 is HIDA scan with ejection fraction. Next is MRCP, and the last one is ERCP. So, Robert, neoadjuvant Gleevec is you're right that for certainly indicated unresectable or borderline GIST. However, even in patients who are resectable, there is a logic behind it, and the tumor board may choose to have it in these large ones to see a response, and that's not necessarily harmful as long as the patient is not symptomatic. And it is part of the guidelines now that it can be used in a neoadjuvant fashion in that way. Okay, 92% of the people got it correctly. You're looking for biliary dyskinesia at this point, so I agree with that answer. We'll go on to the next one. An 80-year-old female remains intubated after aortic valve replacement due to her history of severe COPD. On postoperative day 5, she develops a temperature of 38.6, pulse of 119, and white blood count of 14,000. Right upper quadrant ultrasound demonstrates pericystic fluid and a defect in the gallbladder wall. What is your recommended treatment? Intravenous antibiotics, percutaneous cholecystostomy and intravenous antibiotics, early cholecystectomy and intravenous antibiotics, transpapillary endoscopic drainage of the gallbladder, and percutaneous abscess drainage and intravenous antibiotics. Yes, Sarah Miller, you are correct. If there is low-grade dysplasia, there's no harm in doing endoscopic mucosal resection or even an open mucosal local excision with respect to that adenoma we were talking about. So the answer here, well, the majority got it wrong, so let's discuss this. And this is a challenging one, and it seems like a lot of people miss this for a reason. Look at the question again. This is a patient who has not just acute cholecystitis, but actually has a gangrenous cholecystitis, and that's why it says defect in the gallbladder wall. And so what happens in these patients is basically a watershed issue in the sense that they basically have ischemia and necrosis of the gallbladder wall. So as you can imagine, even though she is sick and intubated, as you can imagine, this patient won't get better with just antibiotics, and the cholecystostomy tube won't necessarily fix the problem because you basically have a perforated or a necrotic gallbladder. So although she's sick and intubated, the right answer is actually early cholecystectomy and intravenous antibiotics, which is basically C. Questions about that, please ask away. This is a very common error because people confuse a really sick patient with acute cholecystitis and then don't realize that there's a subset which is gangrenous or perforated cholecystitis, and in those patients surgery is indicated even though they're sick. But if you have somebody who is septic and has cholecystitis, and I think we have a question like that coming up, not to give it away, those patients, yes, the answer is drainage. Okay, so the next patient is an 80-year-old man who is postoperative day 14 for exploratory laparotomy and enterotomy for gallstone ileus, who has returned to the emergency department obtended with a fever of 39.3. Heart rate is 110. Non-invasive blood pressure is 95/40. White blood count is 16,000. Serum is 1.5. Total bilirubin is 1.7. His wife notes that he complained of right upper quadrant pain prior to becoming confused. Plain films of the abdomen show a non-obstructive bowel gas pattern. What is the most likely diagnosis? Adynamic ileus, closed loop small bowel obstruction due to internal hernia, cholangitis, small bowel perforation. Excuse me. Death. Emphysematous gallbladder can sometimes respond to cholecystostomy tubes, which is a little different than gangrenous. And so you can treat those patients with cholecystostomy tube and see. However, if the patient is truly septic and you think it's gangrenous, an emphysematous gallbladder can be synonymous with gangrenous, so be careful with that. In those patients, you should take to the operating room. So back to this question, yes, the vast majority got it right. It's cholangitis. The situation here is that the patient has a fistula between his gallbladder and his duodenum. That's how he passed the gallstone ileus stone. And through that fistula, you can have reflux cholangitis, just like you do when you have a coloduodenal anastomosis or a biliary enteric anastomosis. So.
And for our last question.
44-year-old woman in the ED with fever, nausea. Sorry, I'm looking at my, okay, 44-year-old, I'm looking at my paper handout, I apologize, Mike. 44-year-old woman in the ED with fever, nausea, vomiting, right upper quadrant pain. Ultrasound shows obstructing cystic duct stone, column bile duct within normal limits. You do a lab chole, but convert to open due to severe inflammation. You unintentionally enter the duodenum and repair it. It was stuck to the gallbladder, which you remove. Post-op day 4, NG tube output remains high. Upper GI with small bowel follow-through, no stricture or leak, but contrast does not reach the cecum by 12 hours. CT shows high-grade obstruction in the distal ileum. At re-exploration, you find the gallstone impacted in the terminal ileum. How to prevent this obstruction, this finding? So, a resection of the inflamed bowel with primary anastomosis, use of percutaneous cholecystostomy, use of perioperative bowel prep, and then meticulous intraoperative examination of the small bowel. Danielle, can you explain your question again? I'm not sure I completely understand. What's so the majority got it correctly. Obviously, this patient had a fistula, and which would pass the stone, and so when we took care of the right upper quadrant, we didn't pay attention that there was already a stone that had passed into the small bowel and later caused an obstruction. She meant with gangrenous cholesterol. You also need to take into account removal. Yes. Performing versus. Oh, I see. Yes. Well, that makes sense. Again, that's also another reason to remove a gangrenous or a dead gallbladder.
Dr. Alseidi, thank you very, very much for that excellent review of hepatobiliary, and we really appreciate you contributing to the webinar every year. And I want to thank all of our faculty for their contributions, and I want to wish best luck to all of the residents in the audience who are taking the ABSITE this coming January. Good luck to you all. Again, we want to thank SAGES as the sponsoring society. I encourage you to all think about SAGES as a professional society to join. We want to thank SCORE for the questions that they've provided this year, and hope to continue that in the future. And then finally, we really, really appreciate your feedback on trying to improve this every year. We look at every single comment and take it seriously. In your Adobe Connect software there, you're going to see a link on the right side in the web links section there for the survey. We really appreciate you just taking a couple minutes to fill that out and give us some feedback. That concludes our webinar for 2018. Thank you again, everyone, for joining, and again, good luck on your ABSITE.